Welcome back, Focus Learners. Today's explainer is covering a truly fascinating and honestly quite complex medical topic, systemic sclerosis. Now, at first glance, this disease can seem like a massive, overwhelming puzzle. It touches so many different parts of the body in ways that might feel totally disconnected. But as you'll see, once you understand the underlying biological mechanisms, that whole puzzle comes together perfectly. By the time we finish up here, you're going to see exactly how microscopic cellular changes translate into the macroscopic clinical symptoms we see in patients. Let's get right into it. Here's our roadmap for today. We're going to define systemic sclerosis, explore the pathogenic triad, compare the two distinct clinical subsets, examine autoantibodies, look at bedside staging with nail-fold capillaroscopy, and finally detail the major organ manifestations. Section 1. Defining systemic sclerosis. So what exactly are we dealing with here? Well, systemic sclerosis, or SSC for short, is a complex autoimmune disease. The absolute distinguishing hallmark, the thing you'll almost always see, is scleroderma, and that literally translates to thickened, indurated skin. But here's the catch. What makes this disease truly systemic and potentially life-threatening is the internal visceral organ damage that comes along with it. The fibrosis and the vascular damage, they don't just stop at the surface. They go after the lungs, the heart, the kidneys, and the GI tract. Oh, and just to keep us on our toes, there is actually a very rare subset called SSC sign scleroderma. In these cases, patients experience all those classic internal organ and vascular issues, but their skin completely spared. Wild, right? Section 2, the pathogenic triad. Let's look at the biological roots. The core engine driving systemic sclerosis is best thought of as a triad. The pathogenesis isn't just one rogue pathway doing all the damage. It's actually three completely distinct but heavily interlocking biological mechanisms. Imagine three gears turning each other. When a genetically predisposed person encounters some sort of environmental trigger, these three domains kick into gear and feed off one another, creating a really vicious cycle of damage. Let's break down this rule of three. First up, we have microangiopathy. This is basically widespread injury to the tiny blood vessels, which leads to leakiness, vessels dying off, and eventual tissue ischemia, meaning tissues get starved of oxygen. Second, we have inflammation and autoimmunity. The immune system essentially goes into overdrive, pumping out highly specific autoantibodies and activating specialized T and B cells. And finally, the third pillar, visceral and vascular fibrosis. This is the ultimate end-stage consequence. The early autoimmune chaos and that vascular reactivity essentially trigger the body's fibroblasts to go rogue. This culminates in massive, irreversible scarring, extracellular matrix deposition that permanently replaces healthy, normal tissue architecture. Section 3. Two distinct clinical subsets.
Now, clinically, patients are broadly grouped by their pattern of skin involvement, and incredibly, this skin pattern actually predicts their internal organ risk. It's a huge clue. On one side, we have limited cutaneous SSC. This disease course is usually indolent. It moves slowly. The skin thickening is limited strictly to the fingers, the distal limbs, and the face. A major hallmark here is Raynaud's phenomenon, that painful vascular spasm in the fingers when they get cold, which can actually precede any other symptoms by years. Historically, this subset is linked to what's known as crest syndrome. Then, on the flip side, we have diffuse cutaneous SSC. This one is rapid. It's aggressive. The skin thickening quickly moves up from the fingers to the proximal limbs and the trunk of the body. In these patients, Raynaud's usually kicks off at the exact same time as the skin changes. But the most crucial takeaway here, these diffuse patients are at a much higher risk for early, severe internal organ involvement. We're talking rapidly progressive lung fibrosis and life-threatening kidney crises.
Section 4. Autoantibodies and diagnostic clues. Time for some molecular detective work. You can find circulating anti-nuclear autoantibodies in virtually all patients with systemic sclerosis, and they are incredibly specific. They tell a story. Let's map them out real quick. Topoisomerase I, also known as SCL70, is highly associated with that diffuse, aggressive subset, particularly with early-onset interstitial lung disease. Centromere antibodies, on the other hand, point toward the limited subset, bringing a higher risk of isolated pulmonary arterial hypertension. Then we have RNA polymerase III. This is another marker for the diffuse subset, and it is absolutely notorious for predicting a scleroderma renal crisis. Finally, autoantibodies like fibrillary and Th/2 are usually tied to specific overlap features involving the lungs and muscles. What's absolutely fascinating is how these mutually exclusive antibodies actually look under a microscope. They literally glow in completely distinct patterns during immunofluorescence testing. For instance, centromere antibodies look like these discrete, bright, speckled dots. But then you compare that to Sclerosis, which gives off a much more diffuse, scattered glow. Or you might see the distinct, glowing nucleolar patterns typical of RNA polymerase III and fibrillary. Just by looking at the specific visual pattern, clinicians instantly get a massive clue about the patient's likely clinical trajectory.
Section 5. Staging with nail fold capillaroscopy.
Okay, moving from the blood to the bedside. By simply placing a drop of emergent oil on a patient's cuticle and using a low-power microscope, or even just an ophthalmoscope, we can physically see the hidden microangiopathy of the disease happening in real time. It's like a window into their vascular health. Normal nail fold capillaries look like these perfectly arrayed, uniform little hairpins. But in systemic sclerosis, this microvasculature undergoes a terrifying, but very predictable evolution. Let's trace how this damage builds up over time. In the early stage, the very first thing you notice is abnormal vessel swelling. You get these giant capillaries and symmetrical dilation. It's the pressure building. As the disease progresses to the active stage, the vessels just can't sustain it anymore. They suffer microhemorrhages, literally tiny bleeds right into the cuticle, and they start to collapse. Finally, we hit the late stage. Here, we witness massive vascular dropout, also known as rarefaction. The normal vessels are just gone. They've been replaced by fibrotic scarring, with only a handful of chaotic, disorganized new vessels desperately trying to survive. This tiny DU perfectly mirrors the much larger ischemic damage happening inside the internal organs.
Section 6. Major organ manifestations, the macroscopic impact.
So as we know, the lungs are a massive target in this disease. If we look at high-resolution CT scans of the lungs, the contrast over time is striking. In early-stage interstitial lung disease, or ILD, you might just see subtle ground glass opacities. It looks kind of hazy, representing early active inflammation. But in late-stage extensive lung fibrosis, the picture is totally different. You see coarse, thick, reticular honeycombing and something called traction bronchiectasis. The normal, delicate, spongy architecture of the lung has been completely obliterated. It's been replaced by rigid, avascular scar tissue. And you can imagine, getting oxygen across that thick scar tissue, it makes normal gas exchange nearly impossible. The most crucial thing to take away from all of this is that the pathogenic triad leaves a destructive footprint everywhere it goes. Beyond just lung fibrosis, we often see pulmonary arterial hypertension. This is driven heavily by that microangiopathy pillar we talked about, which constantly remodels the small pulmonary arteries until eventually the right side of the heart fails. Then there's scleroderma renal crisis, a sudden, life-threatening spike in blood pressure paired with kidney failure, perfectly showcasing just how severe the diffuse subset can be. And of course, the cutaneous findings. Sclerodactyly, where the fingers get very thick and curl inward like claws, painfully hard calcium deposits under the skin known as calcinosis cutis, and those dilated visible red blood vessels on the face called telangiectasia. We've tracked this disease all the way from its interlocking microscopic biological triad to its devastating macroscopic impact on the organs. It's a remarkably complex puzzle, for sure. But it leaves us with an incredibly provocative thought for the future of targeted rheumatology. Right now, medicine focuses mostly on managing the symptoms and dealing with the late-stage fibrosis. But what if we can learn to accurately intercept the specific immune or vascular pathways of that pathogenic triad in the very early stages, before the irreversible scarring even starts? Could we completely halt this complex disease before it ever truly begins? I really hope this explainer gave you a fantastic, structured understanding of systemic sclerosis. Keep learning, stay curious, and I'll catch you in the next one.